All right, I have started the recording. I'll get us started. Thank you for joining us today. Thank you to the panelists. Thank you to those of you participating today. Thank you to Corey. We're delighted to have this conversation. We're delighted, CFHA, to host this conversation on the Community Conversation platform. So thank you. And we hope that we see all of you in Phoenix and at other events coming up this year. Let's see, I'll just keep the recording going. Corey and I will keep our eye on the chat. And, oh, I know what I wanted to say. We are recording this to then post on our YouTube channel. So anyone that's not able to make it today or interested in it, it will live on that probably within the next 3 to 5 days. Hannah's really great about getting those up fast. So that will be up there. I am Tanya Lauder. I'm the business manager. I have the privilege of co-facilitating the conversations with Corey Knight and just listening and learning from all of you. So without further ado, I'll turn it over to Corey. Thank you all very much.
Well, good morning, good afternoon, wherever the listeners of this might be. My name is Corey Knight, and I am a clinical psychology intern at Community Health of Central Washington. I want to welcome each and every one of you to our monthly community conversation. This month, we're in partnership with the CFHA Pediatric SIG group. So it's an honor to have you all here. I look forward to this topic. As part of community conversations, we definitely encourage participation, questions. Really, we think of this as having some structure and some fluidity. So we will keep an eye on the chat boxes. If any hands go up, anything like that, again, please feel free to chime in. We have a fantastic panel of speakers today. So really our topic is going to focus on behavioral health wellness, getting ahead of the wave. What I'd like to do is just kind of transition over to the panelists and give each of you a moment. We'll start with Maria just to briefly introduce yourself and just share whatever kind of information you'd like to share before we dive in.
Sure. Thank you, Corey, so much. And hi, everyone. So I'm Maria Arrojo. I'm a Behavioral Health Integration Manager for the Pediatric Physician Organization of Boston Children's. So I'm located in Western Massachusetts and supporting a number of practices integrate behavioral health. And some of them are entertaining this idea of the behavioral health well child visit, and others, like one of them here on the call today, has already implemented this in her practice.
I'll keep going. My name is Lisa Tyndall. I'm in North Carolina, and I'm at the Center of Excellence for Integrated Care at the Foundation for Health Leadership and Innovation. And North Carolina is, working through the weeds on trying to get this sort of policy implemented for our state and for our children and adolescents and families. So I have been asking lots of questions, and I'll continue to keep asking lots of questions because I think this is an opportunity for all of the states to kind of figure out what works best for them in terms of this type of policy. So I'm excited to be here.
Hi, everyone. I'm Matthew Tolliver. I'm in Tennessee, so I'm at East Tennessee State University. We have an Institute for Integrated Behavioral Health there, so I work with that, and also the Director of Behavioral Health in our Department of Pediatrics. It's great to see everybody.
I think Sarah's still connecting to audio.
Hi, this is Doug Tynan. I'm with the Delaware Psychological Association. I've formerly been the Director of Integrated Care for American Psychological Association, also the Coordinator for Mental Health for the American Diabetes Association. And Delaware did pass a behavioral wellness bill last year mandating payment for one wellness visit a year, and we'll be talking about that a little later.
Hi, I'm Lisa Powell. I'm a pediatric psychologist and senior policy analyst for Healthy Steps, which is a program of 0 to 3 pediatric primary care program. And we work all in the preventive space. So I'm really excited to be here for the conversation today. Also, I should add that I lead our work in Massachusetts, both in terms of growth and scale of Healthy Steps and also sustainability. Nice to see you all.
Hi, I'm Jamie Devine. I'm an integrated clinician at Pediatric Care Associates. We're affiliated with Boston Children. We're Maria works, and we also are Healthy Steps certified and work with Lisa. Our practice has been offering paired well-child visits since the beginning of this year here in Massachusetts.
Wonderful. And Sarah, would you like to just do a quick introduction?
Sure. Thank you for I was having trouble getting into this. My name is Dr. Sara Hills, and I am the Integrated Behavioral Health Manager for Infant, Pediatric, and OB/GYN Mental Health and Ambulatory Care at Denver Health in Denver, Colorado. And so obviously interacting with our new law for an annual well visit for all patients. We also are the largest Healthy Steps site in the state of Colorado and have been doing preventative care within our Healthy Steps and infant mental health programming for several years. And so come from that experience as well.
Well, thank you all so much for introducing yourselves. I definitely look forward to hearing more about this topic and seeing how your unique experience factors into it. So here's just kind of a breakdown of the plan for today. Introductions, talk about context, legislation by state. We'll have a panel discussion. And again, active questions throughout. I'm going to keep an eye on the chat in case anything comes up too. So with that, who would like to start us off first?
Lisa, you can start. That was the plan, and then I'll just speak about this slide if you want to.
Sure. So we, gosh, this has kind of been a long journey for us, for our foundation. And so this kind of, we arrived at this idea or to talk to each other organically in terms of exploring and asking questions and trying to figure out what other states have done with this annual wellness visit. For the biggest pushes or reasons that we have gotten excited about this is the opportunity to really get ahead of anxiety or depression or just other issues that come up as we grow up in childhood and adolescence. Is a very different place to grow up these days, and being able to have kind of get in front of the curve, in front of the wave, and to also destigmatize the idea of seeking mental health and having these conversations with licensed professionals, to be able to give more language that's accurate and not social media generated. And to also just, this work is already being done in a lot of places and a lot of clinics, and it's just not reimbursable. So I'm familiar somewhat with Healthy Steps and kind of the difficulty that it's been, at least in North Carolina, to get that reimbursed. And it's just kind of mind-blowing that continues to be the case. And we kind of have reached the point where, I know I'm preaching to the choir, we can no longer just keep treating the crises as they arise. We need to kind of get in front of it, so to speak. So I'm excited to learn and continue asking questions, and just, so grateful to be here.
So we started this conversation with Lisa and Matthew, and then we added participants to that dialogue, and it was incredibly rich and rewarding to have a lot of people discussing that together and coming up with this idea of being here today. And when looking at how would we introduce the context for this, well, it turns out that the annual wellness visit that we are all so used to for physical health is not so old. Apparently, and correct me if I'm wrong if someone has found other information, was introduced in 2011, and it was to promote evidence-based preventive care, identify and diagnose risk factors and conditions in aging adults. So nothing to do with the territory of infancy and early childhood back then. Is now an ubiquitous feature of primary care for the whole population and all ages through the lifespan. This new concept of behavioral health wellness visit is much more recent, and we are going to talk to you today about the different efforts that all our states of the panelists here have been involved with to launch this and also develop what are the best practices associated with that additional wellness visit.
Hi, I just want to comment on the can you hear me?
Yep.
Okay. On the Delaware legislation, if I'll take 2 minutes to go over the path that got us here. If I go back 12 or 14 years when Governor Jack Markell was in office, he had a big interest in developing employment opportunities for adults with autism and developmental disabilities based on some experiences he'd had in Finland. And so he was very familiar with that population of adults. And for whatever reason, his staff got interested in early screening for autism. So during his administration in 2010, we passed legislation that mandated that all the insurance companies had to pay for 3 developmental visits at pediatrics at 9 months, around 18 months, and again at 3 years to enhance referrals to the 0 to 3 program. To before that, and that was the 96110 code. That's been on the books, but some states don't pay well on it. We got $11 out of Medicaid, a little more out of the private insurers, and then had a program to train primary care docs on how to do this from check-in to check-out. And one clinic, the Nemours system, which has about 60,000 children, gets about 90% of those visits done and collects and refers a lot to 0 to 3. So that wasn't a wellness visit, but that was just getting developmental screening on the books, but it set the stage. So following up in the last legislative session, same legislators who were involved in the autism or the developmental screening bill proposed a bill to screen annual screening for children. And that was prompted by the COVID epidemic and this rash of increased use of emergency rooms for mental health. They saw this surge in mental health and thought if we did an annual screening, we could catch people earlier. And it expanded very rapidly from screening for children for screening for all ages. One of the legislators said, "What if it's good enough for 10-year-old, 5-year-olds, 10-year-olds, why not 40-year-olds?" Mm-hmm. So that's how the legislation expanded. The bill that was passed in 22, the fiscal analysis was that it would cost $500,000 to start it up. And the fiscal analysis for 24 and 25 are this would run about $2 million of cost to Medicaid to pay for this, and maybe $2.5 million for the other insurers. So they did a fiscal analysis of what it would cost. It does not show what the savings would be, but these are small enough numbers for statewide that there were no objections that this was rampant. At this time, there is a committee whose members I still do not know, this semi-secret committee that's supposed to come up with outlines of what a behavioral visit should look like. It can be carried out by any licensed mental health provider, master's or doctoral level. But we still don't know what's involved. I've made suggestions about what screeners and questionnaires should be involved. Once that is done, the Delaware Psychological Association does have funding from the state to do workshops, to teach clinicians. We are an unusual state psychological association that we have a large number of associate members who are social workers because there is no Delaware Social Work Association. So we have almost 400 members in our state of less than 1 million people. So we are the mental health CE program in the state. So that's my summary of how we've gone. And I want to emphasize getting legislators and getting the governor, lieutenant governor interested, finding some personal story and how this moves it along, and then building logically on existing efforts in your state. And I think the important logic when I looked at the preamble of the bill was the surge in use of mental health, and that would indicate it would be better to catch things early. The big key on this one was the surge of the use of the emergency departments for child mental health crises, hoping to avert some of that by screening annually to catch these things before they get to crisis level.
That was awesome. Doug's the reason. It was Doug's email that that spurred that we read that said, "Wait, why isn't this happening in North Carolina?" So, many thanks for that email long ago. See, CFH email persists. CFHA email persists. Who wants to go next?
Would you all like me to go to the next slide?
Do we want to go ahead and go through the other states, Chus?
Yes, Lisa, do you want to go with California?
Sure, I can go with California. I to be really transparent, I don't know a lot about what was passed in California. It kind of came to our awareness, I guess, through our advocacy group that's helping us with this. But I know Lisa might be able to speak to it a little bit better, the other Lisa. Or maybe that's what you meant, Chus.
I did, but either way.
Well, let me hand it over to Lisa Powell.
Okay, so California is a little bit confusing, and I think there's one piece of legislation and Medi-Cal benefit that passed that was a family therapy benefit that is also hugely beneficial, but it's really more about opening up preventive codes and allowing services without a diagnosis. Then more recently, there was a really innovative package that Medi-Cal put out called the dyadic benefit. There are 4 components to the dyadic benefit, of which one is a dyadic behavioral health well visit. So really innovative and important, and frankly different than what's happened in other states, because we at Healthy Steps, of course, work in the 0 to 3 and 0 to 5 space primarily. So if we're talking about an annual visit, it really is not online at all with parity. We want it to align with physical health visits. And so California did just that. It does align, it's for all visits, well child visits. And it is, as it implies, dyadic in nature, that really is encompassing caregiver health as well.
I can go next with Massachusetts. Legislation passed in 2022, and there is still an implementation in progress. There have been work groups working to decide what should be in the outline of this visit. What the legislation included was that it has to be at no cost to patients, all ages, has to be an annual visit, and by a licensed professional. And that includes primary care physician or behavioral health clinician, either in primary care settings or specialty care. Through the discussions in the work group, it was decided that it should include the screening and education pieces, but also there was some discussion about including mental health status and other elements that are included in a evaluation, a typical evaluation by a mental health provider. Also, we discussed the possibility of having this visit occur at the same day of the existing well child visit, as well as a separate visit, because mental health professionals in the work group were really advocating for having the possibility of conducting this visit in specialty mental health, and that would have been impossible to align with the existing well child visit, as we in integrated care would love to have happen. So.
I can add a little bit about Colorado. Sara is our Colorado representative. But Colorado was also a state that we spoke with early on, and similar to what Doug said, they had a legislator that was very passionate about this work and really drove the work to getting it passed. But you can kind of see their outlines, and we reached out to Sara. Sara, what would you like to add from your experience? Famous last words. You're on mute.
Okay. Can you hear me now?
Yes.
Okay. So I would say it has been passed and it is somewhat in effect. So we've learned from our own insurance associated with Denver Health that insurance companies are not sure what to do with this law. And so we're seeing a variety of different ways that insurance companies are trying to cover this visit, from counting the very first visit of any given year as the behavioral health wellness visit, regardless of the content of that visit, to telling us that they already have behavioral health visits covered in general, so don't need to do anything different for this wellness visit. Our own Denver Health medical plan for our staff is internally funded, self-funded, and so exempt apparently from this law. And we don't have that coverage internally. So we are having conversations with our own personal medical plan about adding this coverage for the coming year. And I think the biggest conflict we're having is that there's a difference between what an insurance company thinks is a coverable visit versus what we think is a clinically relevant wellness visit. So at this time, they're not requiring that we put much into our documentation because they're not actually worried about it being a wellness visit. They're just choosing to cover based on it being a behavioral visit, and that we'll give one a year. But prior to this legislation passing, we've been doing preventative well care for young kids for a very long time. So we are able to bill using H codes for our prevention care, including Healthy Steps and our infant mental health work. And so we do that in conjunction with the well visits, but also have some covered visits that occur outside of the well visits, either connected to them, but not on the same day, or as our brief therapy visits covered through Medicaid. So as far as insurance coverage of prevention for well child visits, we continue to work on that, including with our own plan right now, where even to be in Healthy Steps, and if you're a part of the Denver Health Medical Plan, you have to pay a copay for a well visit. So it's a mixed bag, and we're finding we just all have different objectives and different ways of interpreting what a well visit is at this time. So ongoing conversations.
I'd like to comment on that for a moment, and Sarah brings up a couple of great points. First of all, the ERISA plans, the self-insured plans, are not covered under the Affordable Care Act, so they can still get away with whatever they deem as important. I know that's about 20% of our insurance plans in the state, including the one that covers University of Delaware employees, but they generally go along with it. And then second, the critical point of having a wellness visit is since it comes under the Affordable Care Act definition of a preventative service, then there should be a zero copay. That's very specific in the Delaware legislation that there's supposed to be a zero copay for these visits. So there is no obstacle, there's no fiscal obstacle to having a person go through these. And then unlike some of the other plans, again, this specifically mentions licensed mental health providers and also mentions that this does not preclude, or this does not substitute for the annual wellness visit with the primary care provider, because the only opposition in the hearings was from the Family Practice Association that were fearful if somebody came in and had a mental health wellness visit, then they couldn't do their annual well check. And so that's very clearly laid out in the legislation that these are two separate wellness visits. And they're not allowing the primary care docs to do the behavioral health wellness. It has to be a mental health provider.
Oh, wow.
I can speak to Tennessee a little bit. We're in a really different place, and I'm kind of joining the panel from a state that is not really even on the starting line around some of this stuff. So we don't have any legislation pending that I'm aware of that, or a really strong organized advocacy effort around this. But one of our pediatricians, Karen Skatsina, last year got a Tennessee Department of Health grant to expand integrated services, among other things, at ETSU. And so as a part of that, we are going to move forward with designing these behavioral health well visits kind of regardless. And I think we're going to be focusing more on, because we don't have legislation or other, insurance company requirements, just trying to design it to be what's the most clinically meaningful and practical for people and families. We're running a kind of a pretty strong PCBH model. So trying to think about how would you incorporate this in the context of that kind of service delivery model, and leveraging a lot of our trainees as well, who might come in. We think that even though we don't have the codes turned on, maybe like other states, I think a lot of these visits, once you go in, there's going to be some kind of an issue that comes up that we could maybe able to bill, a psychotherapy code for anyway as a behavioral health consultant, but having it be very prevention focused and kind of linked, like Lisa was saying earlier, to not just an annual thing, but at every well-child check age, starting at birth, having some sort of prevention component that we could add in.
Mm-hmm.
Yeah, I'll just add to that, Matthew, that maybe, I mean, one of the other things that I know quite a few states have done now is to really try to advocate for preventive services, right? So perhaps a limited amount of services, like in Massachusetts and Colorado and California and several other states that have been able to sort of unlock benefits for people without having a behavioral health diagnosis. So really in the preventive space, that allows them to receive services without reaching that threshold of clinically significant impairment and a diagnosis. So just another sort of strategy in order to do this kind of preventive work.
Yes, that's great.
I'll just say for North Carolina, we are sort of still very much in the middle between, we've done some, I would say the last couple of years, but most intensely the last 6 months of talking to stakeholders and various professional disciplines and community members and payers and clinics, and trying to see if this was something that was palatable and doable, and continue to receive feedback to massage what it might look like. And we're just kind of continuing to move forward. We're probably coming to the end of that with a couple of critical conversations, but the overwhelming response from people has been extremely positive. A couple of hesitations that we get are the workforce concerns, which I combat with the life-giving nature of preventative conversations, and that is an infusion of positivity and hope in a workforce that very much needs it. And I don't think, similar to what I think Colorado has experienced, is there will be a major influx of people demanding these visits right away. So I think there's time to, adjust and get upscale. And also we just can't use that as a reason not to proceed with what needs to be done. So, but that seems to be the biggest concern. So with the exception of the individual stakeholders' concerns themselves. So for the most part positive. I think we can move to the next slide, Corey.
So yeah, I just thought I would sort of lift up another maybe avenue for doing some similar work. So we talked a little bit about California, but I thought I would just mention these other states that you see here that have achieved a similar goal for having behavioral health providers at well-child visits, and that is through an enhanced payment strategy. This is a little different, and probably I should have said other team-based care versus a behavioral health well exam. But in these states, Maryland, Arkansas, and New Jersey, these are recent additions and benefits for members that really have to do with practices that are providing evidence-based, team-based care. So Maryland was the first to sort of pass something like this, and it really is tied to a $15 enhanced payment for Maryland Medicaid that includes actually well and sick visits in practices birth through age 3 that are identified as Healthy Steps practices that we give an attestation that they're at fidelity or approaching fidelity to the model. So another way to add providers to PCP's visit. Same thing in Arkansas. Actually, I should say Maryland was really with negotiation with state Medicaid, whereas Arkansas and New Jersey went through a legislative process to enact similar benefits. So those are still new. They are sort of still in process of being negotiating. Actually, Arkansas is currently rate setting. But again, theirs is a little different too, tied to practices that are already PCMH accredited that are then committing to providing evidence-based, team-based care. And same thing in New Jersey. Recent legislation, theirs was again a little bit different, allocated $500,000 in their state budget for evidence-based team-based care with a federal match. So they are currently, it's a new benefit, and they're still working through what that exactly might look like. I think one of the other things I think is probably important for conversation is just this, the difference between legislation passing and then actually it being operationalized, both in terms of building out what does a well exam look like, and how do you bill it? What's the code? I mean, there's just so much that happens after we have sort of these big wins that we celebrate, like this went through, but then actually having it in action, I think is a different process and can be lengthy, I think, as we're seeing in lots of these other states. So I'm curious if other people know of other states other than these that we've talked about too, that have passed either a behavioral health well exam or an enhanced payment for team-based well child visits.
Yeah, again, to emphasize what you just said, in Delaware, the legislation was passed in July or signed by the governor 15 months ago. There was a committee of 2 pediatric psychologists, 2 adult health psychologists, 2 primary care providers, I think 2 members of the public that was supposed to produce a document that says what should a well visit look like. Billing codes were included in the legislation, and reimbursement rates were estimated between $125 and $160 for that visit. So rates were set, everything else was set. And like I said, I'm sitting here waiting because I have separate money from the state to roll out the CEs, and they haven't given me the content yet. And so, yes, you got to think about all those steps. What does it encompass, and how do you train people to do it, and what will the reimbursement rate be, and the billing codes? And if anyone wants to share, I do have the fiscal assumptions that were developed by the Controller General for the state when they generated costs. Because once you get into hearings, it's like, what's this going to cost? Nobody cares what you're going to save. They want to know what's going to cost and how you're going to pay for it. That's one thing I've learned. Nobody. If you're going to do a program, it's going to save a lot of money, and we know something like Healthy Steps saves an enormous amount of money. I've done enough work with Head Start in the past. Yes, that does save money, but they just want to know what the implementation costs are. What's it going to be over the next fiscal year?
Lisa, I have a question about this. Are all these state innovations that you added reimbursed for state insurance? Do any of them include commercial insurances? Because in my opinion, the novelty of the behavioral health well child visit as compared to the preventive codes in Massachusetts, for instance, is the ability to have the visit even if you have a commercial insurance as a payer. I think that's probably what got in the way to utilize the preventive codes more broadly, or at least for us in our organization, because it would only apply to Medicaid kids.
Yeah, it's a great point. And no, they do not. These are with state Medicaid in particular. But you're right. That is one of the things I think from an advocacy perspective that it's important to think about at the state level. Like, how do we, if it started as a Medicaid benefit, how can we expand and advocate with commercial insurance as well? Because from a practice standpoint, it's very complicated when you have practices with a payer mix where some patients have these benefits and others don't. Yeah, it's a great point.
I think innovations, though, in Medicaid, shame is a powerful tool, and also working with unions and employers saying, here is a benefit that Medicaid offers, and you've got full-time employees with supposedly good health insurance, and your insurance company is not offering this. So we go right to employers, large employers here, Gore and Amazon and those big companies that are based here. we just say this is a Medicaid benefit. Your employees should have that same thing. It usually takes about 1 fiscal year for that to happen. And some of them, like Highmark Blue Cross, will jump on the bandwagon right away and proclaim how wonderful they are for providing the same. So again, these are not really backroom things, but ways to put pressure on employers and on others for if Medicaid is a good benefit. The same has been true of Medicare. Good benefits in federal Medicare, the private insurers usually comply within a year or two, but you have to put pressure on them.
Yeah, I'd like to echo that too, Doug. We are definitely doing that with our Denver Health Medical Plan in the hopes that doing so will then allow us to influence our other private insurers. And I think our biggest barrier right now is just how the private insurer defines the behavioral health well visit. This idea that it can be just the first visit of the year is ludicrous. And so we're trying to get that point across to them and having meetings about that to apply that pressure there too.
So hopefully I'll have a definition soon that I can share with everyone of how it's at least defined in one state.
And I put in the chat, if it's helpful, how California defines the behavioral, the dyadic behavioral health well visit. Theirs is a little more built out, I think, than we've gotten to in some other states.
One of the other things that I've been trying to advocate for on a policy level is coming back to the folks that were involved in the passing of this legislation to say this is great for, you know, our older kids, so essentially over 3 through adults, this annual well visit, but not comprehensive enough for our early childhood population. And I've gotten a lot of interest back, and with the caveat that they've already selected the things they're going to be promoting for the next legislative season, but they would like to keep this on their list and keep conversations going. So I'm hopeful that this at least opens the door to more conversations about why we need to increase the number for our youngest population.
All right. Well, I appreciate like that kind of macro perspective view of the combined efforts across the different states. I think there's some phenomenal work being done. And I really think this is going to have tremendous ripples for the communities in these states too. So just to kind of move along for the sake of time, I'm going to jump into the questions for the panelists. So we'll go ahead and start off with the rationale. So why do you think this movement towards behavioral health well child checks is important / relevant / needed?
Amy, you haven't spoken yet, so I hope you can jump in on this one.
Sure. We've been doing these behavioral health well child visits since January, and it was the focus of my doctoral capstone too. And I think part of the reason that it's so important is that we can't continue to react to mental health once concerns arise, right? And we heard the mental health crisis, and we've heard about flooded referral systems, but like, what about teaching people what to expect or how to, like, you know, anticipatory guidance for development? And so it really, to me, stems from that like population health model that the well child physical is already based on, and just pairing it that we can't separate our bodies and our emotional well-beings, that we are, you know, all inclusive human beings, and all of these pieces need to be addressed. I'm with Sara. I would love to see this done for all well child visits, including those, the 13 between newborn and 3. And for our Medicaid patients, because we have some flexibility in how we can structure them, we're able to do that, but I would love to see that universal. And for me, the reason it's needed is well, look where we are trying to refer kids in this reactionary measures, and look how long that takes. And if we just keep reacting, we're always going to be trying to put out fires instead of actually, you know, building strong, emotionally stable, well cared for individuals.
Yeah, I think it just helps destigmatize too behavioral health. And, you know, pediatricians do a great job, and, you know, pediatric medical providers do a great job at these well child visits, giving anticipatory guidance. But if you look at AAP Bright Futures content, there's like an hour's worth of stuff to go over in every one of these visits. And so there's just no way to cover all of those important topics from a prevention standpoint, I think, just from a medical provider perspective. So I think it opens up another avenue for covering some of that content that we know needs to be covered, that's locked into that developmental stage. But I think behavioral health providers may have a little bit more time to be able to dig in a way that leads to change, for the better for the family. Because I think it's easy to, get into the mode of, don't talk to strangers, make sure you wear a helmet, make sure you wear your life jacket, but not have always the time needed to really delve in to see what do we need to dial into for this particular family, and what are they most at risk for, that we need to come up with a prevention plan for.
And I'd like to add that we need to be really thinking about the upstream work that we're doing, because we do so much, as was already mentioned, reactive work or remediation work. We already know the return on investment, not just financially, but emotionally, and in terms of lifespan and well-being, is impacted by early intervention work. And I would like to add that the idea that someone has commercial insurance, and that somehow implies that they are more heavily resourced than someone does not, is inaccurate. And so I think that we need to quit kind of putting people in buckets and assuming we know what they need based on what we think from the resources they may have access to.
The child clinician in me is sort of coming up, and I know in the past the most frequent referral for elementary school and middle school age kids has been for ADHD and oppositional behavior. We also know from the research on those disorders that they tend to emerge around age 2, the first symptoms and signs. And if we could screen at age 2, not just for development, but for behavior problems, and we have effective behavioral interventions. You can help parents learn more effective skills of management. That just goes a long way to preventing what happens down the road. When I first did integrated care in a pediatric setting, all I got was 8 to 12-year-olds, and after about 3 years, I was seeing the 3 and 4-year-olds. And so, I mean, I just think that's how we should be thinking, and how we should be promoting. You would say to someone, you test for tuberculosis. You don't wait till it's full-blown case. You test for any infection early to catch it early, or cancer. And I think we have to use those metaphors, those analogies, when we talk about these things, that a lot of behavioral disorders kids do not grow out of it. They just get worse. And I think that's so we have to have good ways of presenting this to the public, to our legislators, and also to our colleagues in general medicine and pediatrics, and that we have effective means dealing with of working with younger children that do prevent things from getting worse.
I know we are answering different questions from different segments, which is fantastic, and we don't have any interest in sticking to the single questions and going in order. So I like that, actually. And I also just want to add that for me, the biggest hope is how much this is going to support integrated care. I think we all struggle to make it fit in the existing ways of practicing medicine. And when I heard this was going to be a possibility to do in the integrated care settings, was like, breeze, like clear air. So I just want to emphasize that point and connect it with the implementation logistics questions here, because even though it's fantastic, it comes with a lot of challenges, given how many behavioral health clinicians we have in a practice with multiple medical providers and other practical things like that can affect our ability. So I loved your comments about implementation, not only advocacy, but getting real and how are we going to be able to do this.
I think that's a great point and a whole nother discussion on levels of care, from universal messaging to individual therapy, and what kind of things can we build in to primary care. I know Ohio right now, any parent can sign up for online PPP parent training for a year for free. And that is a evidence-based, internet delivered parent training program. That's great. I mean, that would take care of maybe 70% of the families I used to see.
I think that's great too. And I also think it doesn't replace the relationship between the early care mental health professional and the family. I know that in my experiences, just doing a well-child visit, the nurse visit, or even the 2-week visit has resulted in families reaching out for additional support for other things that they might need. For some serious concerns, like child abuse and neglect and other situations like that, in which they feel comfortable talking to us because we've first established that relationship.
I just want to say too, I mean, even though like I'm not on the front lines with this, I'm doing a lot of clinical work myself. I think just you all have made some really eloquent points about the rationale and how so much of this ties together and feeds into the advocacy efforts. Just, the idea that really, because this is population health, and we're trying to think about things from a preventative, secondary, and tertiary level, like this work is huge, right? And really, I think this is remedying a lot of problems that our healthcare system has, and really neglecting the needs of families and the individuals we provide care for. And honestly, I think this is going to revolutionize the healthcare industry in so many ways. So I'm definitely very pumped about a lot of the work and, the efforts you all are putting in, and I think something that comes to my mind too is with some of these questions around advocacy and logistics, with what we have here, it sounds like there's a lot of work being done and there's a lot of work to go as well.
I think that's a good point, that there is a lot of work to go as well. I think since I'm new to the advocacy piece, I didn't realize how long it would take, how long it would all take before we begin. And I think Colorado, Sara's experience and reflection on the hiccups and whatnot along the way has been really helpful for me, and kind of a reality check of all the fine tuning that needs to go into play. Of course, I'm just still hopeful that we'll even get over the first hurdle. But I wanted to speak too to the idea, I think when I look at the prevention literature, which is new to me, to be really transparent, and you see the broad universal stuff that's delivered perhaps in the school systems or in the more as group work, sort of, to me, this sort of mental health well visit helps take that to the next level and give it the same level of weight and credence that we think about physical health. And I think one of the things that we've run into sometimes when we talk to providers is they say, well, we're doing that already. And it's technically supposed to be. And like Matthew said, I love the way you said it, it's an hour's worth of material. And I think you're doing the best you can. But as a parent, I know I've never experienced what I'm hoping my child would get. So just being able to kind of individualize that. And as a therapist and a parent, my children still think they have to be crazy to go see a therapist. And I just want to get past that point where we don't feel like that anymore. And so to me, when you normalize or validate this experience, these conversations at this level with a licensed person, it becomes obviously less scary. So anyway.
What you're saying, Lisa, is for me connects with the importance of us being at the table, integrated care organizations and individuals, because my experience with our work group in the state was that they had no clue how to think about this for an integrated practice. Mm-hmm. Therefore, the stigma was perpetuating in the ideas, like it has to be a separate visit, a separate service. There has to be obtained as a consent because no one wants maybe to have this share with the doctor, there were a lot of comments that made me really nervous about those pieces. And I realized, you know, these were mental health specialists, there were medical associations as well, that it surprised me how little they knew how this could be fluid in integrated care versus having to make specialty care be the place. Not to mention that we are struggling to put all those kids in specialty care. Why would you use primary care for that service? You know, let the prevention happen there, and then you make space for the kids when we need to do those referrals. But we were not able to have our voice going through you know, too much, because I think we had a lot of other voices that couldn't grasp the concept. So for those of you who are starting it, I think that's my biggest takeaway from what my experience was, you know, get in there and help them understand what integrated care can do with this.
Yeah.
Maria, I think, you know, one of the things that we've experienced in Colorado is that we've seen such an increase in sudden unexplained infant deaths. Our rates are higher than those for teens who complete suicide. And of course, we know that our number 1 and number 2 causes of death for pregnant people and postpartum people is accidental substance overdose and suicide. So those have been loud in our state. And I think those loud concerns have started to really bring that push for destigmatizing mental health and getting our, you know, leadership in this state to really pay attention and to think about what we can do early to save these deaths, prevent them.
And I think the climate has changed. I know in our state of 10 years ago, you or even 5 years ago, if you asked for universal screening for mental health in public schools, there'd be a large segment of the community that would push back very hard, saying we're violating parental rights, and there'd be a lot of conservative-based opposition. Given what's happened now with the increases in anxiety, increases in suicide in adolescence, I just don't see the resistance we used to get. It's not full-scale acceptance of mental health, but at least it's a lowering of resistance.
Yeah, for us, it's like when Chus said, like it's hard for people to get it. I've had multiple conversations where people say, well, we screen. And I'm like, yeah, yep. And and what comes after that screening? What's next? And being able to say, if they don't screen positive, if there's no actual concern or diagnosable thing, do you still have a conversation, or do we just like say, whew, and like move on out the door? And that has been a really big, I would say, in 80% of the conversations, getting people to really think about it from that perspective has been hard.
Lisa, that brings up another barrier that we've encountered here in Colorado, which is that much of the billing that happens for prevention in the world of medicine happens because of the prevention task force list of things that can be billed. And none of those are mental health. They're all medicine. The screening is there, but not follow-up on that screening and other things that we could use for codes. And our insurance companies are adhering to that prevention task force information, which just simply doesn't include behavioral health.
I think it'll be interesting too to just see what do these visits look like, right? I mean, even within this group, maybe it would be different, and I think that makes it harder to study too, the potential impact of the visits. But it seems like it's really going to come down to like what screeners are we using, what is the purpose of the visit, what kind of things are incorporated in terms of the impact it's going to have. And so that's one thing that made me excited about this group, is like some ability to get to a best practice standpoint and kind of shared understanding around what would make one of these behavioral health well visits something that would be impactful and lead to change for people.
Well, I appreciate the points that have all been made, and I'm wanting to move to a slide on barriers. I'm looking for it. Chus.
Yeah, after the Q&A, I think
okay.
I think build the slide of the questions for the participants for people also to take home and think about those questions themselves. So not necessarily we were in an hour going to answer all of that. And obviously the Q&A at any time, they can stop us or unmute or do whatever they want. But since some were talking already about what are the challenges and the opportunities, for the sake of time, I thought maybe we should land here. I think you guys were mentioning the lack of guidance. Someone mentioned the insurance objectives versus the clinical ones, allocation of resources as well, billing all along. I also mentioned the ratio of PCP-VHC and the need for training and so on. I think that none of this is new, but it's the kind of thing that I think anyone starting to think about how to implement it is going to run into.
Yeah, I mean, just looking at this list myself, I mean, there's a lot of different things that come up for me in terms of, I can only imagine how many states are so behind in their level of integration that it's even a struggle just to approach these simple ideas of workflow, scheduling, ratios. And I guess one thing that comes up as well is, how does this fit into the well child checks, right? Because if we got to cover these basics just to meet these needs, and we're asking PCPs, the clinic schedule, BHC schedules are going to get a lot more full now because this is becoming a mandatory requirement. How do we kind of balance some of these new demands, given if you're already in a clinic that has a high usage of BHCs and now increased well child checks are going to fill the schedule? What do you do to kind of balance some of this out?
You said something that is very important that I don't think we mentioned, at least for Massachusetts. This is not a mandatory service, which also risks the implementation. It is mandated to be offered to all the patients, but it's not mandated to perform the service. So this is exactly why some of these barriers could get in the way for a clinic to take on this and decide to really implement it.
Same for North Carolina, I think, is our goal, is just that it would be covered, but not mandated to do.
I throw this out there because we pair our visits. So they're pre-booked on the schedules with their well child visit, which has been really helpful. And I know I'm a tiny practice with a kind of a unique demographic, so I don't pretend that this will reflect everywhere. But since we started in January, even the month of January, about 50% of our patients accepted those visits. And we're up to, on average, between 80 and 83% of our patients accepting those visits on a monthly basis. So I think, yes, the workflow is a challenge. Yes, building the schedule is a challenge. No, what I do in this practice is not going to work everywhere because, life doesn't work the same everywhere. But we really dedicated ourselves to this was how we wanted to practice. And we have gotten an overwhelming response. I actually think better than we had initially sort of projected, just 9 months into it.
I think it's a very real barrier, though. I mean, even when we take a look at a large organization like Denver Health, where we've grown from 4 specialists who see 0 to 8 to 15 in just 2 years, that's still just one person in family medicine who sees the 0 to 8 population. So anytime we talk about increasing anything, taking into account the new recommendations to screen 8 and up for anxiety or all of the things, our providers get very concerned for us. They want to keep us safe and they want to keep us in clinic and avoid burnout, and they're not wrong. It will be a tremendous lift. It will require more people. And it might require considering something like we use for Healthy Steps when we think about enrollment criteria for Healthy Steps, to kind of start to triage the population of who do we want to target. If universal access is the goal, but it's not possible for us, how will we try to triage who gets these visits and who we offer them to?
Yeah, I appreciate y'all answering that. I want to stay cognizant of time because I know we have about 2 minutes left. Just kind of wrapping up things. I see, Matthew, you had a comment here in the chat. I think we should consider the ability for other folks like community health workers to deliver some of these services. Absolutely. Absolutely. I think that's going to increase access and reach so much more when we can, grow the support and the forces for implementing this sort of thing. So with that, just any final comments, ideas with the little bit of time we have left?
Well, we want to put a plug to our presentation in the conference, which is exactly about this topic. Hopefully, Jamie will have an opportunity to explain a little bit more of the implementation. And also we want to share these resources for all the participants and whoever watches this later on that they can use to build this.
All right.
Go ahead, Corey.
I was just say with that, I guess we'll wrap up here. Tanya, feel free to jump in.
Thank you, everyone. Thank you to all of our panelists. This is great information and great conversation. Hopefully we can pick it up again another time, maybe revisit it as things move forward in each of these different states. And we hope to see all of you at future CFHA events. Thanks again.
Okay.
Have a great rest of your day.
Thank you so much. It was
Thank
great
you.
to be here.